Good afternoon, everybody. Welcome to our Palliative Care Echo Series. Today we're looking at incorporating a palliative approach into your primary care practice. And I'm Stephanie Hendrickson. I'm the coordinator for the Northwest Regional Palliative Care Program, St. Joseph's Care Group Echo Hub site, which is part of the National Echo Project led by Pallium Canada. And I myself work as a knowledge broker at the Centre for Education and Research on Aging and Health, or CERA, at Lakehead University. I'll be the moderator for you today, and we're very pleased to have Dr. Erin Gallagher here to speak with us. So just a little bit about the Palliative Care Echo Project, if you're not familiar with it. It is a 5-year national initiative aimed at cultivating communities of practice to establish ongoing professional development among healthcare providers who care for people who could benefit from a palliative approach to care. If you do visit Pallium Canada's Echo website, you'll find tons of different Echo sessions led by Pallium and also the various hub sites, and they are all free of charge. So I encourage you to check that out. And while we're joining each other virtually today as the host of this session, Lakehead University respectfully acknowledges its campuses are located on the traditional lands of Indigenous people, and Lakehead Thunder Bay is located on the traditional lands of the Fort William First Nation, signatory to the Robinson Superior Treaty of 1850. And Lakehead University acknowledges the history that many nations hold in the areas around our campuses and is committed to a relationship with First Nations, Métis, and Inuit based on the principles of mutual trust, respect, reciprocity, and collaboration in the spirit of reconciliation. Here at CERA, we're committed to working towards reconciliation and decolonizing our work, and have committed as a staff to educating ourselves in these areas, both professionally and personally. So for myself, I do continue to seek out opportunities that I feel are beneficial to my own journey of truth, reconciliation, and cultivating an understanding of different ways of knowing and learning. So we would love to know also where you all are joining us from today. If you want to give us your name, your role, and where in the country you might be, that would be great. So please do feel free to introduce yourself in the chat as we get underway. Just some quick housekeeping before we get to our speaker for today. Your microphone is muted. However, you're welcome to use the chat function. We are hoping to have some time at the end for questions, but if we do run out of time, Erin is happy to follow up afterwards. We'll ask you to do a quick session evaluation for us before we leave today, and we are recording the session, and it will be emailed out to everybody who registered within the next week. So with all that being said, I'm happy to introduce Dr. Erin Gallagher. She is an associate professor in the Department of Family Medicine at McMaster University. She is a family physician and clinical supervisor at Stonechurch Family Health Centre in Hamilton, and a palliative care consultant for the McMaster Family Health Team and Hamilton Health Sciences hospitals. She sits on the palliative care educational committees for the Department of Family Medicine and Department of Medicine and its subspecialties. Erin is also the medical director at Emmanuel House Hospice in Hamilton and the Ontario Health West Physician Clinical Co-Lead for Palliative Care. And her academic interests include public health approaches to palliative care, building capacity, and and competencies for palliative care in primary care, and leadership development for medical trainees. So we thank you very much for being with us today again, Dr. Gallagher, and I'll stop sharing my screen so you can take the floor.
Sounds great. Thank you so much. Big thank you to Pallium and Lakehead University for inviting me to come and be with you guys today. And thanks for all of you for showing up. Also want to thank McMaster University because they play a big role in supporting my continued learning around these topics and, of course, many more. Just one real disclosure today, the first one being that, yes, I am a clinical co-lead for Ontario Health West, but the lens and the hats that I'm bringing today are Erin Gallagher, palliative and family physician. A caveat with family physician, you will hear me say family physician, family doc, general practitioner, primary care. I will be using these terms interchangeably, but I'm really referring to anybody that is in a position of looking after somebody with a progressive illness and has that, privilege of continuity along their journey. The second bullet point there, why do I put this up? Well, they've undoubtedly influenced my experiences and my conclusions and my perceptions around this type of care. It's, I believe, impossible to call myself an expert in a palliative approach, no more than it is to call myself an expert in the human condition. But man, I've learned a lot since 2008, and certainly well before 2008 in my own personal life with losses. If I had it my way, we'd all be in a room together, learning from each other. But of course, that's not possible today. And maybe some of you will extend the invitation for us to have those conversations. But today, I am sharing with you some of the things that I've learned since becoming a family physician. There are deficiencies all around us when we do this type of care. We see them every day. And I have learned a number of strategies that have really helped me navigate these deficiencies. And what I think makes this presentation unique, I am hoping for you, is that I am trying to be as practical as possible around what I bring to the table and consider the day-to-day flow of primary care in family medicine. Although you may not use the word flow these days, it does seem a little bit more turbulent, doesn't it? I also come with assumptions. The first one being that palliative care and the palliative approach specifically is everyone's responsibility. When we train on the palliative approach in my clinical settings, everyone from the reception staff to the clinical people are involved. And that's because we all influence the experience of our patients and our families. And not only that, everybody who does this work is impacted in some shape or form and will have to navigate this in their personal life. So it's a win-win to be involved regardless. Primary care is the backbone of the healthcare system, and family medicine specifically is ideally situated because of our comprehensiveness and our continuity. And then finally, I love giving this presentation because I strongly believe that delivering a palliative approach and incorporating it into your practice is incredibly rewarding. And I want others to experience that reward as well. Sometimes it can be even instantly gratifying. I've done a lot of ear flushes this week, and anybody else on the call who's done one, you can appreciate what I mean by that instant gratification. We don't get it a lot in family medicine, especially as we treat more chronic conditions. But when you have somebody walk into the office, they're frustrated, they can't hear, and you do an ear flush and suddenly they can hear again. It's just so gratifying for everybody involved. And I have those experiences in palliative care too. This water bottle, many of you may recognize. And the story is about a young mom who I treated with metastatic breast cancer, and it had gone to her brain. And unfortunately, as a result, she was losing function of her hands. Also, because it had gone to her brain, she was thirsty all the time. And so her very tired, very wonderful husband, who had spent all day looking after her, was up all throughout the night trying to help her navigate just taking a drink, and working with the complexities of the various water bottles that we see out now. And this is what popped into my mind. It's because I am a hockey mom. And we've got these bottles all over the place and we lose them regularly. And I tried to explain to the family, who was not a part of hockey culture and actually new to Canadian culture, what this is. But instead, I just got in my car, I bought the $5 bottle and I gave it to them. And, this probably had the biggest impact out of anything I did for this family. And it had nothing to do with medicine proper. It was just using some creativity, thinking outside of the box a little bit, and truly listening. So very rewarding work for me. And I hope that you are already experiencing some of the rewards yourself. A little bit about our context. I mean, I think in primary care, our capacity is way down because we are overwhelmed. We have major problems with continuity and hanging on to our patients. And, it's no surprise that over 50% of our patients are still dying in hospital. And the costs associated with this, of course, are astronomical. With patients, we have increasing diversity, not just in the patient themselves, but in the medical conditions and the chronicity of what it is that they're presenting with. That predictable decline from diagnosis to death is not really what it used to be, with there being more interventions and more options for people. It's often said that we have a death-denying society, and I question this because I know whenever I come in and I do a consult or I'm involved in, public-facing conversations about death and dying, the opposite seems to be true to me. We just don't have the avenues for having these conversations that are appropriate and comfortable. So I'm not so sure about the death-denying piece. And then as clinicians, our comprehensiveness is declining. There's research showing this now, and it can be attributed to both interest in palliative care, but also incompetence, because our training is also quite variable. And then practice models, depending on where and how people are doing this work around us, it can diminish our competency, especially if there are a specific group of individuals that are expected to take over the care when people approach end of life. How can we keep our skills up if we're not expected to do this ourselves? So I, of course, don't have all the answers for these variables today, but it's important to recognize them. And I just want to make it clear that my intention today is not to fix these problems, but to give us some tools and some ideas for working smarter in what we're already doing and not necessarily harder. So I'm going to start with presenting a case. This is Sam, a 66-year-old man who owns his own construction company. He lives alone in a home that he owns, and he's lost his wife to cancer 5 years ago. His son lives in the same city with his own family and works for his dad. A daughter lives out of province. He's been a long-term patient of the family practice, not typically seeking care until recently for recurrent respiratory infections. He's a long-term smoker, and in investigating him for COPD, an incidental lung nodule was found on chest X-ray. So I think in reading this and knowing Sam's risk factors, I'm clearly concerned about him. And in encounters like this, I'm already jumping way ahead. I'm thinking about the fact that Sam lives alone, that he's a business owner and might not have benefits, that he potentially has more than one substitute decision maker. He's not one to seek care, and he's still smoking and will likely require things like oxygen therapy down the road. But this is where we reach our first fork in the road. I often refer to our healthcare system as hammer and nail. Nail here, of course, being a suspected malignancy, and the hammer being oncology or surgery, depending on where we would refer to next. And it truly is missed as an opportunity to clarify for patients what happens if we do put them down this usual path, and whether it is exactly a path that they do want to entertain. It might seem silly to some of you to think about not referring to surgery or not referring to oncology when we're worried about a malignancy, but I assure you, I've had patients that didn't want to go there for very good reasons for them. Maybe something that's easier to wrap your head around is a patient who has been in the cancer system for 5 years or so. They are now seem to be in remission, and we get a note back from the specialist saying that they need to have, breast exams every 6 months and a mammogram every year. And it's easy enough for us to set these things up. But the question from me to the patient becomes, sure, we can do this, but what are our goals in doing so? If this cancer came back, would you want to know? If you did want to know, why? Is it because you'd want to be as prepared as possible for what's to come, or would you actually consider going through those treatments again? Those are two very different reasons for going down one path versus the other. And then where somebody is diagnosed plays a significant role as well. Often I diagnose patients, but sometimes, unfortunately, they're diagnosed in scarier environments like the emergency room or with a specialist that they don't have a rapport with. And so it's my responsibility to bring them back, to bring them into my office and to continue to be a part of the trajectory. So I spend a fair bit of time preparing my patients around what to expect. I use language like, yeah, we're going to refer you to the cancer center and things are going to move fast. They're going to be really busy. You're going to want more time with the people in front of you, but it's unlikely that you'll get it. Ways that you can prepare yourself is by having a notebook, writing down questions that you have before you go, bringing somebody with you who can be an advocate and an extra pair of eyes and ears, and making sure that you come back and you follow up with me. Because like I said, you are going to get a lot of information and you may not remember everything that was said to you. I will get a progress note from any follow-up you have, so I can try to fill in some of the pieces. And if I can't, I know where I can ask for the answers to those gaps. And so Sam is referred to a lung diagnostic program after discussing this with him, and this results in a diagnosis of metastatic cancer. So we need to identify our patients that would benefit from a palliative approach. And we've been stuck on early identification for years. And I think a big part of this is because, sure, we can identify patients upstream, but we really need to know what to do with them after. And that's going well beyond just the hammer and nail that I talked about. When I came out of family medicine, I felt very confident in diagnosing things and breaking bad news. And then in retrospect, when I did my palliative care training, I recognized that I was really good at end of life care. Because of my training being mostly in tertiary care centers and late referrals, to be honest. It was within the realm of family medicine that I learned how to navigate a patient deserving a palliative approach from diagnosis to death. Ideally, we start this early, and that's where advanced care planning plays a role. So over time, we get to know our patients' values and wishes, and it doesn't need to be a formal advanced care planning conversation. It can be, but ideally, we're getting this information over time. How early are we with Sam? I'm not exactly sure. I don't know where we are yet. We need more information. Moving more down the trajectory, we commonly think about a palliative approach when people get a formal diagnosis of cancer, when they're admitted to long-term care, sometimes, when they're started on second or third line therapies, when they visit hospital, often more than once. If we're smart enough or aware of the surprise question and use it the way it's intended to be, if is the patient in front of me, would I be surprised if they died in the next 6 months to 12 months? And this goes beyond progressive illnesses like cancer and congestive heart failure or COPD. In family medicine, this also includes people with severe mental health conditions. One of my biggest losses was a young patient who had severe anorexia nervosa and committed suicide. And I recognized, very quickly in treating her that a palliative approach was appropriate. And then, there are other opportunities. So the people that come into our office and we're seeing them more, or we see a change in their function or their frailty, or a family member comes in and is concerned. All too often, we're identifying these people when the wheels have fallen off. Maybe we've diagnosed them with something, maybe somebody else has, but the referrals have happened. They've been caught up in the vortex of a complicated system. Suddenly, the patient physically can't make it in to that system anymore. And so family medicine is left to pick up the pieces. And then the missed patients, which are beyond the scope of today's topic, they're the ones that stop visiting us, that face social isolation or other structural barriers. And then our unconscious biases play a role here too. When I ask you to think about a patient with dementia, it's still elderly white woman who pops into my head. Who are we missing? So I've recognized lots of opportunities throughout my career for broaching some of these conversations as early as possible. We still have patients that want to do annual physical exams. And I mentioned that I do advanced care planning with all of my patients because my job is to help you live as well as you can for as long as you want to. For people who have had losses, often they're thinking about their own mortality. And I ask them if they are. For people who have visited hospital for themselves or for a loved one, if it wasn't a good experience, how can we make sure that that doesn't happen again? A health scare, asking people, what were your biggest fears when you were in that situation? Cancer remission, we already talked about. Discussing family history, our thoughts about what our death is going to be like are often influenced by deaths that we've seen. And if we've seen good or bad deaths, especially bad deaths, often we paint that as being our future picture as well. So that's another avenue for talking to people. And then we can use language like I wish, I worry, I wonder. So, in general terms, it can be, gosh, I wish things were different for you or were different for your loved one. And I wonder if these are things that are making you think about your own mortality. And I would like to invite you to come back to actually talk about this, because I worry that if we don't carve out the time that it deserves, that, we're going to miss the boat on this one. So inviting back is a key part of what I do. So Sam was referred to oncology through the lung program. He's had his first appointment and is aware that the cancer has spread beyond his lungs. He has some testing, which makes him eligible for a new treatment, which he will start next week. So again, those trajectories from diagnosis to death are not necessarily what they used to be. I've learned not to make assumptions in this type of care. Never assume that the patient knows what you think they know. When I give these sessions with my learners training to be family docs, I ask them the last time they asked a patient what COPD or congestive heart failure was, and most of the time they haven't. And when I ask them to practice with the person sitting beside them, they actually really struggle. So there's a lot of stuff that we assume our patients know that they don't. Don't assume how they like to know information. And this could be, if I'm talking to Sam, are you the kind of guy that likes to know all the details about their health? Do you want to know everything? Don't sugarcoat it. Give me everything to help me make decisions for, down the road. Or are you more of a day-to-day guy? You find too much information at once a little bit overwhelming. So that's some of the language that I use with patients. And I always ask permission to divulge information, especially if it is more concerning information. At the same time, patients make assumptions about what we know. So, if I'm not talking about prognosis or I'm not talking about the fact that this is stage 4 cancer, then, chances are everything's okay. Those are assumptions that are made. And then assuming how people are doing. We have to lay eyes on them. And this becomes more concerning in the world of virtual care. We're not laying eyes on our patients as much. And this is an opportunity to miss those really important subtle changes that tell us that we're in a different stage of somebody's trajectory. So I have had to sell myself to my patients. I didn't think I would have to do this, but over time, I have had to make it very clear for my own benefit, but also for patients, what my role is. Generally, I, describe myself as a quarterback. I'm somebody who can make sense of all the moving pieces that are going to happen for them in their illness. But more specifically, I've broken it down into 3 buckets. I can help you understand your illness and your overall health. And if you have any questions that I don't have the answers to, I know where I can look for them. The second bucket is whole person symptom management, and that's beyond physical symptoms. It also includes psychosocial symptoms, spiritual symptoms. And then the third is planning ahead. So with Sam, we're not exactly sure what's going to happen with him, but we know that when people plan for various outcomes and have those challenging conversations up front, we actually have the evidence to show that people live better and often live longer as a result. So you offer to review the oncology consult note with Sam, but first clarify how he likes to receive information about his health. Sam wants to know everything. At this stage, I'm commonly asked, what do you do about those people that don't want to know anything? The ones that we call deniers. And I will just give some reassurance that if this is done well over time, it is exceedingly rare for a patient to stay and want to stay in the dark for the entirety of their illness. So patience does go a long way. But in the meantime, we can always do what the Waiting Room Revolution podcast refers to as walking two roads. And this is an opportunity to hope for the best with your patient. You can walk alongside them and hope for a miracle with them. There's nothing wrong with that. But at the same time, you're doing them a disservice by not planning for alternative outcomes as well. I remind people that often when they don't talk about these things, what they imagine their future to look like is often much scarier than it actually will be. And so after talking openly with me about some of these things, they tend to feel better. They tend to feel lighter. And if patients do want to continue being in the dark, out of the know, I strongly emphasize that somebody has to be in the know. So we can tailor information to people. We just need the patient's permission to be able to share medical information with their loved ones, caregivers, substitute decision makers, because somebody needs to know and plan to make sure, especially if the patient's goal is to stay at home. So when it comes to family medicine and advanced care planning, ideally, we're doing this all throughout getting to know our patient over years. And then when decisions are being made about what we do or what we don't do moving forward, we have the medical knowledge to be able to inform those plans and even make recommendations. There are so many great resources out there to help with this. Advanced Care Planning Canada is one of them. And then they actually break down their site into provincial-based resources. And that's important because there are some different rules, regulations, and laws around advanced care planning, especially with medical directives that you'll need to know for your individual province. But a great resource, not just for patients and families, but also for us as providers. Vital Talk is another great tool. So courses on teaching people and giving them the ability to practice these conversations and providing great language to use to really get to the bottom or to the crux of the issue that you're dealing with. There's lots of these resources out there. These are just two that are highly regarded and more well known. So back to the case, Sam's note is riddled with big words, acronyms, and lab values. And I'm sure you've seen many of these before in a progress note. What I've come to see for sure in family medicine is that when I get these consult and progress notes from specialists, they're clearly not meant for me. They are meant for the specialist who needs to review it before they follow up with the patient. There's lots of additional information that I would find helpful, but less and less so. I'm finding that these are not really giving me the information that I need. So I'm often having to clarify things with my patients. We talked about clarifying diagnosis already. Excuse me. We also need to often clarify stage of diagnosis, the location of the body, especially with cancer. It's amazing how many people don't know where it is. Prognosis is something that people often want to know, the intention of the treatment and the impact of someone's function on treatment. These are key things that you'll want to go through with your patient to make sure that they're clear on and, see if they even want this information, but most do. What's really important for us is to make sure that our patients have resources that are reliable. This is just one example, the Canadian Cancer Society. Again, there are great provincial resources out there. One that I use is the Cancer Care Ontario Drug Formulary, because they list all of the oncology drugs that can be used in Ontario. There are information sheets both for clinicians and healthcare providers, and then there are patient-facing sheets. So if we ever have questions about, whether or not a side effect is related to somebody's treatment, that's a great resource to go to. Huge shout out to the great disease-specific societies out there. This is just one example. So the Canadian Lung Society for COPD, for example, Parkinson's Canada, ALS Society, Alzheimer's Society. There's lots of supports for, again, clinicians, patients, and families. Many patients want to know their prognosis, and we actually have a fair bit of information to guide us on what a patient's prognosis will be. When a specialist is asked this information, they will often start with population data, and it's bookended. So, if you have X cancer and you don't do treatment, your average life expectancy is anywhere from 3 to 6 months. So what happens at 3 months? Everybody panics. And then at 6 months, people start questioning everything that they've been told. So bookending doesn't help. But certainly speaking in generalisms, as in, weeks to months or months to many months can be more helpful in that regard. There is some more disease-specific data. I'll show you some examples of that. Functional data is probably the most important. So a spiel or language that I use with patients is that we know how people change and their rate of change. And I mean in their day-to-day function, like being able to get up and out of bed, move around your house, make and eat a meal, stay awake, those basic things. If we're seeing those change on a week-to-week basis, and this is for any progressive illness, then prognosis might be in the manner of weeks to many weeks. If it's changing slower than that, it might be weeks to months. If it's changing faster than that, if they're changing on a day-to-day basis, then, it could be days to weeks that we're looking at. But we do know that a pattern, not a bad day, not a bad week, but a pattern in rate of change of function is probably our best prognostic indicator. Our job is to look at the big picture, right? Not just the disease, not just the population data, but to also consider somebody's lifestyle factors, as well as their comorbidities and anything else that influences their health. I also ask patients what they've been told, right? It's important to know that if they've been given a time frame, and then to ask them what they think about that time frame. What does your gut tell you? Does your gut tell you that you have that long left? Does your gut tell you that you have more time? If it is more time, why? Why do you say that? You get some more insight as to what they're thinking. Illness trajectories are helpful for people to see. So with Sam, he is the blue line here, but he's also the red line here. For the blue line, this is cancer. And I find that the longer that horizontal line for cancer, the more surprised people are when they have that final falling off. And that can be disconcerting for people because often they're looking to blame, or they're confused, or they feel like more could be done. But when they see that this is a common trajectory for people with cancer, with malignant diagnoses, it's a bit of an aha moment to know that this time will come. With organ failure, it's a little bit trickier, right? We have an overall decline in function, but punctuated by exacerbations. And when people recover, their baseline function just doesn't come up to what it used to be. And so drawing this out for people with COPD and congestive heart failure can be really helpful. It can be challenging to predict when that final drop is towards death. We have population data. So this again is from the Canadian Cancer Society. I'm just showing you one example for the 5-year net survival for people with lung cancer from stages 1 to 4. So relevant to our patient Sam. There is some objective data that we can use. This is from the Palliative Care Pocketbook. So specific to COPD, prognosis of less than 6 months can be suggested by things like having disabling dyspnea at rest, having a low FEV1, which is a measure of your ability to blow out air in the first second, increased ER visits, changes to your lungs, not being able to oxygenate, having more weight loss because cachexia is a part of COPD as well. And then tachycardia, your heart having to compensate for how hard your lungs are breathing. And then there are great resources with general indicators of decline. So the gold standards framework is one great example. They also have disease-specific tools, but just another great validated resource for us. So lots there to guide us around prognosis, because again, patients want this information, and we can do our best based on the combination of population data, disease data, most importantly, what we're seeing right in front of us, and we can still give caveats. We still lose people earlier than we think we will. We still have people linger longer than we think they will. There are no real guarantees other than we do know where this is going, but knowing that that information is really important to you and that I have permission to speak about this with you, I will continue to update you as I become clearer around what your prognosis is. Again, language I use with my patients. So Sam continues treatment for the next 12 months. During this time, he tolerates it well, but he did require going to hospital for a complication once. He completed a total of 10 cycles. In one of your regularly scheduled follow-ups, you have Sam complete an ESAS. So why do we use screening questionnaires? We know that if we ask general questions to our patients like, how are you feeling? We'll really only get about 25 to 30% of what they're experiencing. It's also important for the patient to answer these questionnaires, because if we answer them, we tend to under-report their symptoms. And if their caregivers answer them, they actually tend to over-report their symptoms. So you dive deeper into some of the higher rated items on the ESAS. Sam is most bothered by his right-sided rib pain, which has been increasing over recent weeks. And this is where it's important to what we in family medicine call fifing the patient. This is an acronym for feelings, ideas, function, and expectation. So some key bang for buck questions that I ask are, have you noticed a change in yourself? What do you think is going on? Often people are worried that it is related to the progress or the progression of their illness. And what are your fears? What are you worried about when you think about what's happening right now and what this means for your future? There are many common fears that people who are receiving a palliative approach express. Symptoms, of course, is one of them. And my approach to this is educating people about the very large toolbox that we have, especially for managing physical symptoms. For loss of control, I reframe a lot of the discussions that we have around the control that patients do have. They drive the bus. Yes, we have guidelines, but the things that we're doing are in relation to their values and their wishes. They also have a great deal of control over what their prognosis is. Many people fear wallowing for an extended period of time in poor function. And so clarifying how and why that need not be the case can be really helpful. Being a burden to loved ones, really the only tool for this is communication with loved ones, and you can help facilitate that. Regrets and impact, so making sure that people are able to leave a positive legacy for those that they're leaving behind. Legacy therapy is a formal avenue of therapy, but again, imagination is the limit here. And then there's the unknown, right? So we don't have all the answers, but being able to walk alongside our patients in in a spirit of curiosity is very rewarding and validating in and of itself. So for Sam, the pain hasn't been interfering with his ability to work around the house and sleep. He worries that the treatment is not working. After taking a more detailed history and performing a physical exam, you determine that nothing acute is going on. You validate Sam's concerns and confirm that he has an oncology follow-up next week, which includes reimaging. So of course, today, this is not a comprehensive review of symptoms, but I wanted to share some key pearls with you today. First and foremost, have a resource that you can have on your desk or at the bedside that talks about that big toolbox, some of the medications and non-pharmacological approaches, and some of the doses that you can start with or how to titrate. Everything we do starts with the patient's goals of care. So, keeping people comfortable is non-negotiable, but how much we investigate certainly is. Symptoms are often multifactorial in these patients, and so that's a reminder not to stop at the most obvious cause of the symptom. Side effects of the medications that we use can often be used to an advantage. So I often joke that, when I am diagnosed with a terminal illness, I just want an infusion of dexamethasone. I want to keep eating, I want to have some energy, and I want my inflammation controlled. Opioids are not just for end of life. I've started patients with COPD and CHF earlier in their trajectory who are experiencing dyspnea on very, very low doses of opioids, morphine, hydromorphone, and it has made significant impacts on their quality of life. But trade-offs are common. We're always talking about trade-offs in this type of care. And, one of the more obvious examples of that are our CHF patients, I think, where, there's such a tricky balance with fluid management, shortness of breath, getting some of the fluid off, keeping the blood pressure up. Many of you have likely navigated this before. And then action plans are crucial, not just for the symptoms that patients currently have, but anticipating the ones that they're going to have and making sure that they have the tools and resources needed to be treated where they want to be. And again, often that's in their home. So these are just examples of some point of care resources. Of course, there's the Palliative Care Pocketbook. I still reference this all the time. There's another Palliative Easy Guide through McMaster. Very small fee for this. You can use the QR code there, but there's many out there. So suggest you to just have one that you trust and to keep using it and updating it as necessary. To tackle Sam's moderate pain and mild dyspnea, you start him on a regular low-dose opioid with the option of breakthrough dosing. For his sleep, you try mirtazapine, which has the added benefit of increasing his appetite, which is a symptom that bothers him. I highlight this because not all symptoms bother people. And if how we treat the symptom can actually result in additional side effects, it's not necessary to go down that route. So we need to make sure it bothers them. You offer to connect Sam with a counseling resource, but he's overwhelmed by the number of appointments he currently has and would rather hold off for now. He seems more concerned about his son and the stress of running the business. And the silver lining here, of course, is that the son is also your patient. So this is an opportunity to call in the son and have a checkup with him. This is going to be at that point, but things are changing. Sam's scans show progression of disease with increased size of the left upper lobe mass, presence of multiple pulmonary nodes, and worsening lymphadenopathy. The consult note outlines a plan to start second-line therapy, and his next follow-up with you is after completion of 2 cycles. He's not tolerating the treatment well. And so we're going to dive in even more to goals of care here. And this often requires significant tinkering and clarification around quantification and qualification. So, people accept palliative intent therapies for usually two reasons. One is to prolong their life, but rarely is it asked by how much. Why am I doing this? Is it to buy myself perhaps a few more weeks, perhaps a few more months, maybe a year? It might change if the oncologist believes that, it might actually be just in the manner of weeks. And so there's trade-offs, right? What are you willing to sacrifice in order to gain a bit more time? Especially if that time, a big portion of it, is spent in the hospital. And so when I'm meeting people like Sam, who I know well, I can talk about the changes that I've seen in him. I can recognize, the losses that he's already experiencing, like being able to do work around his home, spend time with his grandchildren, any of the other hobbies or things that bring him joy in his life, and being worried that time in the hospital will actually take away from this further. So we're regularly needing to change focus as we sprinkle in this approach. And there are many forks for this. We've talked about disease modifying therapy. Another fork is, often people get to a point where they will not go back to hospital, even if it means that they are sacrificing the treatment that might prolong their life. And so action plans become essential in that regard. Life prolongation is another fork in the road. The spiel that I use with people is we're all on a spectrum. On one end, there are some people who would do anything to live longer. And this is really rare. We see this in my experience in young parents. We also see it in people who just want to get to a specific event. And then on the other end of the spectrum, there are people that define their quality of life as so poor that they wouldn't want anything done to prolong their life. And then there are people in the middle, right? Who, yeah, life's not ideal, but they'd like to stick around longer, and they're still willing to treat potentially reversible conditions or complications that are inevitable in their illness. So such as treating an infection. And so when you describe that spectrum to somebody, often people can identify themselves in it. And of course, we emphasize that comfort is non-negotiable, right? Comfort is non-negotiable throughout the whole spectrum. We're always going to try to keep people comfortable. Pills and appointments are another way that we can try to eliminate the burden for patients. Often they have multiple specialists involved. They're taking multiple medications that maybe just don't have the same benefit anymore. And so we can review these things and see if we can take ownership over some of the care that they've sought elsewhere. So Sam is wanting to prioritize time with his family, being at home, avoiding hospital visits, and minimizing symptoms. After a discussion with his care team, he decides to discontinue his second-line therapy and to focus on best supportive care. This slide's a bit of a checklist. So these are things that certainly can be discussed well upstream, but certainly as you approach end of life, want to make sure that you have discussed. So what is the patient support system? Do they have benefits that can fill in gaps for care, especially if there are limitations with the family? Because a lot is on the family. I have to paint a very clear picture for people who want to die at home, what the limitations are for home care. We have incredible people doing incredible work in home care, but at the most in our region, we're getting maybe 2 or 3 hours of care a day, and the rest is on the family. Not only that, but you have, people showing up at different times and with different faces, right? So the continuity isn't always there, and people can struggle with that. But if you tell them up front what to expect, it can be easier to accept. Wills and estate plannings and funerals. I try to introduce this in a benign way with people by mentioning that, I have some patients that even before a diagnosis, they've planned their funeral and they've got their will set up. Sam, are you one of those people? Are you a planner? If he is a planner, great. If he hasn't planned those things, would he like some help with those things? And then, I talk a lot with my patients about the toolbox that we have for managing symptoms. Before MAID, I would always reassure them with the fact that very rarely did we require using it, but we had palliative sedation in our back pocket if we couldn't get on top of a symptom that was causing undue suffering for a patient. And, again, introducing in a benign way, this is just my approach. I follow it up as well with, and, we live in a country now where physician assisted dying is legal. And, it's maybe something you've heard about before and something that we can always talk about if you have any questions. Sam's function improves a little after stopping his second-line therapy. Nevertheless, he consents to a home care referral to ensure his symptoms and function remain closely monitored. After a few weeks, he finds it more challenging to get to the office, and you start visiting him at home. His daughter has decided to come back home to look after him with the support of the compassionate leave benefit. So, of course, there are benefits through the Government of Canada to support caregivers. They're on the Government of Canada's website. And then people who live outside of Canada, their visas can be supported by documentation from us as treating providers to come and to stay in Canada to care for a loved one. Again, information is on the Government of Canada website. So clearly we're heading here towards end of life with Sam. And we need to make sure that there are action plans in the home so he can stay home, which is his goal. Of course, all our action plans are informed by goals of care. We would anticipate somebody with COPD and lung cancer that they are going to have progressive dyspnea and associated anxiety. So we'll want to make sure that oxygen is in the home or can be put in the home, that all medications that would support these symptoms are available and in various modalities. And then, of course, non-pharmacological therapies, just as important. So things like having a fan and having cold cloths available for anxiety attacks or attacks of being more dyspneic. If recurrent infections have been a problem, having a prescription on hand, the bottle in the house or a prescription at the pharmacy. And then when's it appropriate to call 911? Often these can be an incredible resource, this team for people in our region. The paramedics have stepped up in incredible ways to support people who are deserving of a palliative approach. And so grateful for their ability to uptrain in the palliative approach and support our patients. We all need friends in this work. And if you haven't identified these people yet, I suggest that you do. You might have a colleague with more expertise in your community. There are inpatient teams and outreach teams that are often very open to a phone a friend consult. Hospices are a great source of information. You can do online e-consults. There are MAID outreach teams and provincial lines. Pharmacies are great for medication questions. You want to know where your 24-hour pharmacies are in the event of an emergency. Your interventional resources, so where can you get a paracentesis? Where can you get a nerve block? Obviously, that's going to be easier in some communities than others. And then how can we divert the emerge, right? The paramedics, again, are doing an amazing job for many of our patients in this regard by coming to their homes. But there are also outpatient and inpatient mechanisms, depending on the community that you live and work in, that can support this. When we're planning for death, home is plan A for most people, but we always need a plan B because patients and families don't always anticipate or truly grasp how challenging this can be. We need to educate around physical and cognitive changes, and I've included the palliative performance scale here because it lists expected changes that we see as people approach end of life, with their ability to ambulate, their ability to do activities, look after themselves, eat a meal, and stay awake. They are going to lose oral access, and we need to make sure that when this happens, we have a mechanism for getting subcutaneous medications into the home so we can continue to treat their symptoms. Having a DNR or an AND form in the home is also really important. These conversations are often had as a menu item, I found, or people are scared into it by being told that their bones will be broken or it will be painful and traumatic for the family. But as you get to know your patients, you can make recommendations based on what you know is important to them. We know that people at the end stage of a progressive illness, if their heart were to stop or their lungs were to stop and they required resuscitation, their chance of survival is about 4%. And that's not leaving the ICU. That's not leaving the hospital. And, in most cases, it's a 0% chance of going back and, working in the garden, as I talked about before, or having meaningful interaction with the grandchildren. And so we can make recommendations and put it in a patient's context. So when poop does hit the fan sometimes, people understand why they made the decision that they did. Families need to know who to call when death occurs. A lot of people think this is 911, and that's the last group that you want showing up for an expected death. In our region, it is the nursing agency that can come and do the nursing pronouncement if a letter of understanding has been filled out. Sam's visiting nurse calls the clinic to give an update. Sam's PPS has fallen to about 30%, and he's having trouble swallowing the remainder of his medications. You arrange a symptom management kit for anticipated lost oral access, and you call the family to let them know what this means. So this is an example of a symptom management kit in our community. We want to treat the symptoms that Sam is having and anticipate some of the other symptoms that he might have. We also want to only order the medications that are needed, because we want to avoid waste. We don't want to avoid things that we don't think that they're going to need. And so again, in our region, we have nurses coming into the home, drawing up these medications and educating the family how they can inject these medications into the patient's, most often butterfly, again, contributing significantly to the patient's care. So at end of life, the nursing agency calls the office the next morning to let you know that Sam has died overnight and they've completed the pronouncement. His body has been taken to the funeral home and they will require a death certificate, which you complete electronically within 24 hours. This is just a screenshot of what's unique about the electronic death certificate in Ontario. We just have to send the password to the funeral home that the patient is going to. And so this can all be done electronically. It's a bit of a game changer. In our community, we've actually seen clinicians not follow patients because of the concern around having to be on call to fill out a death certificate, which is really unfortunate. But this eliminates that barrier, which is wonderful. Grief and bereavement is another very big topic. And in family medicine, we can help with normalization, acceptance, expression, support, and staying healthy in other ways for our patients. We can help with anticipatory grief. I think about our patients who have dementia. And it is so challenging to navigate that dynamic between trying to facilitate autonomy for a patient who is learning their cognitive abilities and their physical function with the well-being of the overworked caregiver who is just constantly worried and scared of their loved one's safety. And then there's delayed grief, right? We have patients that come in and see us who have been caregiving nonstop for years for somebody. And when that patient dies, they're lost. Suddenly they just have to redefine themselves and sometimes even their self-worth. So family medicine plays a huge role, as does local support groups, religious and cultural groups, funeral homes, and various disease societies, which I talked about earlier. Canadian Virtual Hospice, another great tool, again, for patients, families, and us as professionals for all things palliative approach, not just grief. And then I promised, making you guys consider today some practical considerations. Make your EMR work for you. Identify your patients that are receiving a palliative approach so that when they call in, those receiving the call know that the care is very unique and specific. Identify the team and the contact information that is supporting your patient and use shortcuts in your EMR. make sure that people can access you, whether that be backlines or a cell phone number. It's got to be incredibly frustrating for our visiting nurses to try to get through to our primary care colleagues when, they've got a list of people to go jump from home to home during the day, and all they need to do is have a brief conversation with somebody. Schedule home visits for me. This is every Tuesday afternoon. It's the last hour. I take on a lot of orphan patients, so those who don't have a family physician, these spots are always filled. Know your billing codes, know your community resources, keep collecting them, private and public, and keep these documents that I spoke about on hand. A little about billing. These are just Ontario billing codes. This is not comprehensive, but it's just an effort to put it into context that an average home visit, if we allot 90 minutes to it, is about $350. On the other end, if you're thinking about a family doc that sees a patient every 9 minutes and bills an A007, which is an intermediate assessment, that also comes to $350. The downside is that there's a difference in 8 patients being seen there. However, if you do sprinkle this care in over time and you're proactive with your more complex patients that are homebound, I would argue that over time, it sorts itself out. And then finally, if you're going to do the work to make your practice more efficient and make yourself more capable in delivering a palliative approach, get credit for it. Every year as a doc, we have to do CME training. And so the quality improvement program, you can absolutely analyze your practice from a palliative approach perspective. And then the College of Family Physicians of Canada has the professional learning plan. You can focus this on the palliative approach as well. And so to conclude today, we talked a lot about identifying patients and trying to do this naturally. You do have to sell yourself to them. Don't make assumptions. Always zoom out to know where they are in their illness. Gather resources and not just medical ones. All decisions start with the patient's values and wishes. Make sure that follow-up is scheduled regularly and that you are sprinkling this work in. And feel joy in the work, because it is joyful. And one of the recent joys for me is my work in compassionate communities. As a doctor, I obviously recognize the essential role that we play in accompanying people who are heading towards end of life. But I've also recognized that we're a very small piece of the living well to the end equation. And so compassionate communities is definitely a way for us to advocate to fill some of the gaps that we navigate every day. And last slide, I promise. Sometimes medicine is actually the equation. This is a patient of mine that I took on who didn't have a family doctor. I got to know her very well. And, big personality, super stubborn, wonderful woman, way more riddled than with cancer than you could possibly appreciate on this slide. But, with about 3 weeks of life left, decided she was going home to Colombia and nothing was going to stop her. And so putting together a medical plan to get this woman who had widely metastatic disease, a seizure history, luckily a very supportive daughter who was willing to jump hoops to facilitate this, as well as medical insurance to the country she was going back to. We got her there, and this was a picture that was shared with me. This is her sitting on the patio of her farm back home in Colombia. So sometimes we throw the guidelines out the window, and there's a lot of freedom in this type of care to be creative and really just get back to the joy of the work. So I'm always grateful for having permission to share that story with you. And I thank you guys all so much for giving me your time today and allowing me to run over by a couple of minutes.
Wow, thank you so much, Dr. Gallagher. What a beautiful story to end on. Yeah, I am blown away. That was like the quintessential palliative care approach presentation. I can't believe the amount of information and tools and resources and practical tips and beautiful metaphors that you were able to weave throughout the case that we followed today. So thank you so much. We would definitely love to have you back again.
Thank you.
So yes, just recognizing that we are a little bit over time. Dr. Gallagher did say she's willing to follow up with any questions that may have remained unanswered from our session today. So there is her contact information for you all. And we can also help facilitate that through our center. If you would take a quick moment to do our evaluation, I'm just going to repost that link for us. We love to hear your topic ideas for future sessions. So on behalf of everyone here today and us here at Sarah Lakehead University, thank you so much, Dr. Gallagher. And just to quickly plug, our next ECHO session is coming up November 13th, and we will have Vicki Wilton speaking about managing pediatric patients who could benefit from a palliative care approach in Northern Ontario. So thank you all again for your time, and take good care.
Thank you, everyone.
Thank you, Erin.
Do we stay on? Are we good?
We can touch base offline if you like.
Sure.
Okay, thank you so much. That was amazing.
Yeah, thanks. I'm glad it was well received.
Take care.